Good morning, everyone, and welcome to our discussion on the future of healthcare and AI. I'm Curtis Langlotz, the moderator for today. I'm a practicing radiologist who runs an AI research lab here at Stanford, and I'm director of the Stanford Center for Artificial Intelligence in Medicine and Imaging, or the AIMI Center, which is proud to support this event. We have had an overwhelming response to this event. We have over 18,000 people who've registered from over 140 countries. So we're particularly glad to see all of you here today from around the world. The large audience today, I think, not only indicates a strong interest in the topic of healthcare and AI, but it also shows how interested you all are to hear from our speakers today. No lengthy introductions, so we can get right to your questions, and I'm sure they're well known to all of you, but I'd like to welcome Fei-Fei Li, who is the Sequoia Professor in the Computer Science Department and the Denning Co-Director of the Stanford Institute for Human-Centered Artificial Intelligence, or HI, and Andrew Ng, founder of DeepLearning.AI and an adjunct professor here at Stanford. Fei-Fei and Andrew, welcome.
Thank you, Kurt. Great to see both of you, Andrew and Kurt.
Always fun to have you, Kurt. I have to say, I was really looking forward to this event because actually really looking forward to hearing Fei-Fei speak. I have no idea what she's going to say today, but I was actually really looking forward to hearing it.
Well, likewise.
And it's a great combination to have both of you here together. I'm really looking forward to it. Our event today is co-hosted by Stanford High and DeepLearning.AI and supported by the AIMI Center at Stanford. And I'd also like to thank everyone who worked to make this event possible today. When you registered for this event, you were asked to submit questions, and we have received many really great questions. So I want to thank the submitters and anyone who voted for their favorites. We've chosen from among your questions to guide today's conversation, but we'll spend the last 15 minutes or so taking live questions from you. So please submit those on the HI event website. I'll be asking the questions, sometimes to one of our speakers or the other, sometimes to both. I may chime in from time to time as this topic is of great interest to me as well, but I'll try not to do that too often because I know the audience is here primarily to hear Fei-Fei and Andrew. I know Fei-Fei and Andrew pretty well, but I'm here to represent you, the audience. I may occasionally ask questions I know the answer to because it draws out information I think you may want to know. So with that, let's get started. So Fei-Fei and Andrew, I'd like to start by asking each of you why healthcare is an important area of focus for you and your research. Maybe I'll start with Fei-Fei and then go to Andrew. So as a computer scientist, you could focus your time on many different domains, the environment, astronomy, social media, but you've made a conscious decision to take a significant part of your time and focus on healthcare. So I want to ask you what motivated you to attack this particular set of problems?
Yeah, thank you, Kurt, for asking. Indeed, I've been in the AI and healthcare research space for the past 10 years. And as far as into the future, I'm not leaving this area of research, but it actually really began deeply personal to me. So as you said, I'm a computer scientist, but I'm also a daughter who has been taking care of my mother for the past 3 decades, who is chronically severely ill. And as new immigrants to the country, as the only child of hers, I've braved every single healthcare scenarios and situations with her, from ER to ambulatory emergency to ICU to surgical rooms to long-time hospital stay to home care, just everything you name it. And the 30 years of experience really have deepened my personal understanding of the importance of this industry to every single individual, every single family, as well as just the fundamental importance to humanity as a whole. So from that personal journey to the realization about 10 years ago, our AI technology could be of help to make healthcare better and eventually to make patients healthier, live healthier, recover better. That's why I'm here in this industry.
Wonderful, thank you. Yeah, it's amazing how often personal experiences with the health system can make those motivations, can drive those ambitions. Yeah. Andrew, how about you? What motivated you to get into healthcare?
Yeah, boy, personal level and professional level. Personal level, my father's a doctor. So growing up, in fact, I owe a lot of the fact that I even work in AI to healthcare because when I was a teenager, my father was working on very rudimentary, machine learning systems for medical diagnosis. He's basically fitting two Gaussian distributions and setting some thresholds. But once a teenager, I learned about that and rudimentary neural networks from my father, and that's actually what got me into AI. But growing up in a household where every day my father would come home and tell stories about the patients he was seeing, that always inspires me. And I think professionally, several years ago with the traction in AI, having led AI teams in some large consumer internet companies, I wanted to see where we could take AI outside consumer internet. And I feel like healthcare pattern matches well for me in terms of an important social mission, as well as an industry that is AI ready, in the sense that a lot of industries will undergo digitalization first and then adoption of AI. And the Affordable Care Act, transformation of digital records, X-rays are now digital records. So all the data is kind of sitting there. And we're just waiting for someone to build AI. And then I think lastly, to be candid, all of you watching this, Kurt did not know what I was going to say. So it's just with that caveat. Honestly, one of the things I was really fortunate was I got together with Kurt and Matt Lundgren at Stanford. I still remember the early meetings where Pranav Rajprakar, who also teaches on DeepLearning.AI, where Pranav and I got together with Kurt and Matt, was sitting around the coffee table on Stanford campus. And I certainly didn't know what I was doing, but I feel really privileged to have had the opportunity to learn from great partners like Kurt and Matt Lundgren and Nigam Shah and others that helped me and my friends get into healthcare. And that was a huge part. I think if that hadn't happened, it would have been much harder for me to stick with healthcare for this time.
Well, thank you, Andrew. And for us in the medical school, it's obviously very rewarding to be collaborating with people like yourself and Fei-Fei. These are some of the most rewarding things that we do. So I wanted to follow up. This is a question for Andrew from Andy. Andrew, you've been a pioneer in building systems that provide real-time decision support to doctors. We see a lot of high impact research papers showing that these systems are essentially providing expert performance near what clinicians would provide. Given the kind of performance that we're seeing, why are so few of these models in clinical use? And should we be focusing more on doctor plus AI versus doctor without AI instead of doctor versus AI?
Yeah, I think there are. I think that there are a few challenges to taking the research paper, which is peer review, including papers I contributed to and I will stand behind. But it turns out that just because someone publishes a paper showing that an AI performs at a level similar or maybe even superior to a board certified clinician, there's still a lot of work to take that into production. So all of AI, not just healthcare, I think has a proof of concept to production gap, where by the proof of concept, I mean the research paper or the model running the Jupyter Notebook. With published models where we think that turns out when we collect data from Stanford Hospital, very well-trained technicians, great equipment, and we train and test on data from the same hospital, then indeed we can publish papers showing that we're comparable to a human radiologist in spotting various conditions. Turns out if you take that same model that we just published a paper about, Kurt and I have worked on projects like this, right? Take that AI system to older hospital down the street, older X-ray machine, technician uses a slightly different imaging protocol. That data drift causes the performance of the AI system to degrade significantly. Whereas in contrast, any human radiologist can walk down the street to the older hospital and do just fine. So I think that even though at a moment in time on a very specific data set with same train and test distribution, we can show this works, the clinical reality is that these models, frankly, still needs a lot of work to take to the production. And I think that we need to get better bridging the proof of planning out the full cycle of machine learning project, which isn't just the modeling. It's finding the right data, training a model, deploying it, finally monitoring things, feed the data back, ensure auditing, safety, all of the things that need to be done to make it deploy beyond doing well on the holdout test set, which fortunately or unfortunately is what we in machine learning are great at, but more is needed than that.
Do you think that problem is the same, better, or worse than other industries? Do you think that's unique to healthcare, that sort of gap that you described, or is it something that that cuts across industries?
You know, I feel like I know part of me feels like I should say healthcare is really unique, and I know healthcare is incredibly unique. I see a lot of the challenges in bridging proof of concept to production to be actually quite common across many industries. Now, there's some things in healthcare that are unique. Patient safety, you know, there are definitely some things that are unique, but I see the problems as more similar than distinct. Um, there is one thing that is actually very different from healthcare, which is the business and go-to-market aspect. So for any of you watching this and want to build a startup or something, I do find the business of healthcare, navigating the payer, provider ecosystem, that really is more complicated in healthcare. But from a technical point of view, a lot of the issues about having human in the loop, safety, auditing, these are absolutely critical. Privacy, absolutely critical. They are different in healthcare, but I think there may be even more similarities and differences.
Yeah.
That's my gut feeling. Actually,
Yeah,
I'm curious
great.
what you, Kurt, or Fei-Fei.
Well, I think that you're right. The healthcare system is incredibly complex, and more so than many other systems. It's not as strictly capitalist as some other industries, for sure.
Maybe one lesson I've learned, those of us in machine learning, we're really good at doing well on a holdout test set, and it's a fantastic hammer, and we've built this fantastic tool over the last few decades. Unfortunately, deploying a practical system in healthcare or in other industries often requires more than doing well on a holdout test set. And I think we still need to bridge those other things that are completely legitimate things that also need to be done.
And Fei-Fei, you, I know, have faced these same issues. You've been a pioneer for ambient intelligence. And so how do you navigate the healthcare environment, facilitating cooperation with doctors, other caregivers, when it comes to obtaining the data that you need for machine learning, issues of privacy for patients and caregivers, and how to deal with perhaps the data that in healthcare isn't always perfectly accurate, maybe flawed in some ways. How do you handle those issues in healthcare? Do you think they're unique to healthcare?
Yeah, thanks. What you and Andrew were saying is fascinating, and I resonate so much. Just for the audience out there, ambient intelligence in healthcare is actually quite new. Andrew was saying that healthcare is a AI-ready industry because of the digitization, especially through electronic health record. But there is actually a unique, important space of healthcare that is not digitized, but it is fundamentally important to the human lives of patients and also the work of our clinicians. And it's actually the human behavior, whether you're talking about patients living at home, with chronic disease and hoping they never have signs of deterioration, or you're talking about doctors carrying out their important procedures, hoping that the protocols are met and there's no medical error, or just an ICU patient who is, in the bed but has a risk of safety hazard of falling or other safety issues. All this is the human behavior space of healthcare that we have almost zero data about. Nurses are asked to chart once a while, every few hours, but those charting tends to be very, very sparse and actually laborious to our nurses. So that was the space that ambient intelligence in healthcare we entered with my amazing partner, Professor Arnie Milstein from Stanford, is that we combine smart sensors and backend AI algorithms to illuminate and to see this dark space of healthcare, to see when patients need help, to see when clinicians need help, and to deliver that health critical insight into the workflow of healthcare system. And because of this technology, in fact, it's very similar to self-driving car technology. We use similar sensors and sometimes similar algorithms. But because of this technology, Kurt, you're totally right. There is a lot of human factors, right? First of all, in both the research and as well as the commercialization of this idea, how do we coordinate and facilitate with the nurses and the patients and the payers, the hospital administrators, including the physical facility partners? I think the bottom line, as you guys said, healthcare is fundamentally multi-stakeholder. And it's not driven just by capitalistic goals. It's driven by humanity as well as a business case. So we as researchers take a very, very human-centered approach by involving multi-stakeholders, from the patients to nurses to doctors to hospital administrators, into the room from the get-go to discuss the pain point and how we can make sure this technology is not just dealing with the out of sample performance that Andrew is talking about, but is really delivering insightful value. Yeah. And one particular question, Kurt, you asked is about privacy. And this is a really, really important question. It's actually part of the ethical design of healthcare, and in our case, ambient intelligence. Privacy, fairness, integrity of research is all part of the bigger question. So we have adopted the view actually years ago that ethical design should be baked into the technical system, not just as an afterthought. So on our team, with Dr. Arnie Milstein, we have bioethicists, we have ethical philosophers, and we have legal scholars, all from incredible Stanford, different Stanford departments working hand in hand with us. So from, for example, privacy issue, we look at the modality of sensing. Do we need RGB sensing? Can we use more privacy protected depth cameras or thermal cameras? We look at encryption or security of the device all the way to encryption of the data. We look at different learning models that would actually be much more secure, such as federated learning or different encryption methods. And then we look at how the ethics of consent in research process. And last but not the least, we look at data integrity. Data integrity involves inclusion of different patients, the fairness of data sampling, and all that. So it's really important. I think whoever works in technology and healthcare, I invite all of us to think about the ethical aspect of this technology from the get-go, because at the end of the day, healthcare is about human dignity. And the ethical design of technology speaks directly to the need of human dignity. Yes. So that's how we do it.
Yeah, thank you. And yeah, one of the real strengths of your work with Arnie Milstein is just the fact that we hear in the newspapers all the time about the wonderful medical innovations, but there are so many things that we know work in healthcare, but that aren't actually being done for patients. And so if we can find ways and systems like yours to help us make sure that we accomplish those steps, that's going to be very, very powerful. Yeah, thank you for the insights on privacy as well. We've received a number of questions from our listeners about collaboration and team science. Fei-Fei, let's start with you. What makes a good collaborator, a great collaborator in healthcare or even in another domain? What makes the best team to solve these kinds of problems?
That's a great question, Kurt. And I was reflecting on my own career, and I realized almost all my work is a collaborative work, and starting with my PhD in neuroscience and cognitive science, all the way to healthcare now. So I do have a few, just I don't know if you call it lessons, or the most important thing in my opinion is the humility. We look at science, and especially a hard science like computer science, with such a technical lens. Of course we do the equations, we do the programming, but at the end of the day, we as scientists are humans, and especially working in healthcare, the problem and the stakeholders are people with lives and actually healthcare vulnerabilities. So I think the humility of collaboration is really important. And this is something, just as an example, Arnie Milstein has taught me a lot. We began talking to each other 10 years ago. And I remember literally for a year, I probably understood only half of what he was saying, but I realized just that Arnie's openness to listen to me, to bring me into the world of medicine, to show me from patient rooms to doctors, behind the scene conversations, is a way to humanize what we want to do. And that humility grew on me. And even though I think sometimes collaboration is actually challenging at the beginning because the language set is so different, and sometimes even the objectives, as an AI researcher, we think about the performances in those, whereas the doctors think about taking care of patients. We're not necessarily aligned at the beginning, but with humility, with the multi-stakeholder approach, we come together. And that will be my number one take-home message in terms of multi-team, multi-stakeholder collaboration.
Great. And Andrew, same question to you. And in particular, we have a number of listeners who are saying, I know a lot about machine learning, but nothing about medicine, or I know a lot about medicine and nothing about machine learning. How do I get started? How do I become a part of a high-functioning team to develop these AI methods for healthcare?
Yeah, I think Fei-Fei's answer is a great one. I think just work with great people, humility, and actually I think it's a privilege to find partners that had deep knowledge in sectors that I did not, right? So really working with you, Kurt, and many others over at Stanford Hospital. I think I was privileged to work with, frankly, really great people that felt like wanted my team to be successful, just like I really wanted them to be successful. So I feel really fortunate that, I'm on Slack with a lot of friends, and they all know that if they Slack me and need a favor from me, I'll just do it because they're my friend and I want them to be successful. And a lot of times in my life, I've been really fortunate that I needed a little favor or something, and I had someone I could reach out to, and they just did whatever it is for me with no expectation of me ever being able to pay them back, frankly, although I will if I can. And I feel like being able to build those trusted relationships with people that especially interdisciplinary teams, with me maybe contributing a little bit of the machine learning knowledge and someone else contributing to deep healthcare knowledge, and then hashing it out together. I find that one of the hardest things in AI is choosing what to work on, or project scoping. And I find that I can actually tell you what I used to do when I was a younger academic. I used to get excited about a project and then just jump into the first thing that I was excited about. And it actually sometimes worked out okay. But as I gain a bit more experience, I now find that it's better to sit down with, especially cross-functional partners, me and machine learning, someone else in healthcare, and then to brainstorm widely, a list of possible projects, spend the time to get to know each other so that I can be, reasonably knowledgeable of machine learning and know a little bit about healthcare, and hopefully they'll learn a lot about machine learning as well. And then to have us together look down the list of projects to see, to estimate the technical feasibility of the project, things like do we have enough data, do we compute, as well as the value of the project. So do we think this project will actually move healthcare forward? Is the value to patients, the value of doctors, the highest, or is there an even better project we'll be working on? But I think, all of us are human, and we're all very much affected by the people around us. Social science suggests that we all become a little bit more like the people around us. So I'm willing to, I put a lot of effort into finding great partners to work with, because I'm human and I know they'll influence me.
And do you think, this is for both of you, do you think that you can bring sort of any computer scientist with the right skills together with any physician or healthcare expert with the right skills, and that will create a team? Or do you need the computer scientist to have some healthcare knowledge, or do you need to have a medical expert that can speak the language of AI, at least, so that you have that level of communication? What do you think?
So, go ahead, Andrew.
No, go ahead. I think both sides should learn, but go ahead, Fei-Fei.
Well, yeah, so I think the first half of Kurt's question, any computer scientists and any doctors, the answer is no. I don't think that's the case. I've had numerous experiences that didn't work. I think that's exactly what Andrew said. both sides should begin with the empathy and the willingness not to learn to be a doctor as a computer scientist, and not to necessarily learn to, coding AI as a doctor, but the empathetic willingness of understanding each other's language, of understanding each other's problem statement, and eventually align the goals is so critical. This is, brings me back to Arnie's example. He's such a senior leader when I met him. And I frankly, I hope Arnie's not mad at me if he's listening. I wasn't expecting him to learn AI coding, but his incredible willingness to learn my language, and to this day now he can even speak AI, when I'm not at the meeting. And I think this is what I tell all my students. In fact, Kurt, this is what I do pre-COVID to every student who joins Arnie and my AI healthcare team, whether they're undergrads, master's students, or PhD. I ask them to close their laptop, go shadow the doctors on our clinical team, especially ICU, if I get to choose, and just spend days to understand the human vulnerability and the human dignity and the humanity of healthcare space, and watch how tiring a nurse shift is. Watch how a doctor do his or her rounds and talk about the patients, and watch about the patients and their family members, and soak in that humanity and develop that empathy. And we come back, and then we talk about what problems we can help solving, and we develop that shared understanding of the space of the problem. So I think that empathy is the most important.
Yeah. Actually, I want to add an example. I agree with Fei-Fei. Fei-Fei's words make me reflect on, Anand Avanti, Nigam Shah, Ron Lee, we're working on a project on palliative care recommendations. And so, Anand and team had built a machine learning system that would read an EHR, electronic health record, and estimate the chance of someone dying in the next 3 to 12 months. So it's a surface recommendation for a palliative care or a consultation, or to have a patient maybe filed in the advanced care directive. So as you can imagine, an AI system sending a notification, dear so-and-so, you're at high risk of dying in the next 3 to 12 months. Well, that's actually a really scary thing. And I feel like working through how to have the conversations with the patients, as well as how to rejigger the workflow of the healthcare system to, in a scalable and systematic way, respect the patient, have the empathetic conversation with the patient, or at the right point with consent of family. I mean, telling someone they're at high risk of dying, this is not an easy thing to do. One of the things I'm most proud of is thanks to the work of Ron, Nigam, and others, because one of the really interesting things to me is in the healthcare system, without the data, it tends to be, right, the most senior doctor with the most biggest title that often makes the decision. One of the really interesting things to me with the palliative care work that the team did is by surfacing data, it actually creates space for many other people to recommend for palliative consults of patients that even the attending physician, even the doctor in charge, may not himself or herself have recommended. And so I feel like by opening up the system, which is previously very, relatively hierarchical, as the nature of many healthcare systems, many hospitals, injecting data makes it less the opinion of the most senior person, but creates space for all of the wonderful doctors, nurses, other stakeholders to say, hey, based on the data, I think we should take a look at this patient and see if we need to have this conversation with that patient. And it was really inspiring to me how the injection of these cold hard numbers actually made the system feel more multi-stakeholder and more empathetic.
Yeah, it's such an important point. And sorry.
Oh yeah, so I hope it had not occurred to me that really the team did a great job, that the team could work with the healthcare system to, let's empower nurses to raise for consideration if a patient needs to have this sensitive conversation, and also wound up helping deliver trainings so that more people now are qualified to have this, frankly, really difficult conversation. But I think, and I think we all have had family members that pass away under various circumstances. When I reflect on the passing of my grandmother many years ago now, I wish that there had been someone to have a conversation with her, maybe in a even slightly better way when she was in the hospital in the final period of her life. So I find it, I feel very happy that by doing these cold hard numbers stuff with AI, maybe someone somewhere could have a better conversation with someone's grandmother than maybe mine had when she was in the hospital.
Yeah, it's a critical point. And we think so much about how to release information to patients compassionately, not just AI results, but any result, so that there's a chance for discussion and appropriate absorption of the information. So yeah, excellent point. I wanted to shift the conversation a little bit to something new. This is a question from Ryan for Andrew. How do we ensure that racial biases are not perpetuated by AI in healthcare, as we've seen with facial recognition and in other areas?
Yeah, thank you, Ryan, for that question. I think that one of the challenges of AI is that the standards for bias and fairness are still unclear. Super important. Oh, right, just from an ethical point of view, I've occasionally killed projects, just because I felt they didn't add value. So I personally said, economic case makes sense, but I don't think this moves society forward. I'm killing the project just on that basis. I urge everyone watching this too. If you don't think your project is reasonably fair, reasonably unbiased, moves the world forward, consider just not working on it. In terms of racial biases, I think one of the challenges is that the standards are still a bit ambiguous. And so many large companies today, I've seen large companies not launch a product because they're afraid that they will do something, and then maybe a year later, someone will do an analysis, and then they'll be called out in the media saying, "Hey, did you know that whatever? I'm a man wearing blue shirts. Did you know that you discriminate against Asian men wearing blue shirts?" Probably not that, but some other example that is more politically charged. I think that what I would love to do is, where I think we should shift toward is to have teams brainstorm all the things that could go wrong, right? What are the types of racial bias that are not acceptable? What are the types of gender bias or other protected characteristics? But to preemptively brainstorm a list of, frankly, all the things that could go wrong. My teams do this today. We actually sit down, have a multi-stakeholder team, different disciplines, technical people, medical people. Actually, Fei-Fei mentioned legal people, and I should get more of those. I have to admit, maybe I need more legal people in my teams, but multi-stakeholder, literally openly brainstorm all the things that could go wrong, and then design metrics around all the things that could go wrong, and analyze the appropriate slices of the data. So, for example, we may decide that to protect against unacceptable racial bias, we want to slice the data and analyze the efficacy or the effects or the accuracy on these different slices of data. And then by having a clear standard that we can then audit or check the system against, I think this will allow more teams to deploy systems. But I think the goal of bias is not clear. So step one is to do our best, which will be imperfect, but let's do our best anyway, to articulate what we want and don't want, design metrics, and then audit against those standards. And of course, along the way, have an open mind, because we may discover something after we've deployed the system, but we just totally miss that problem. And then, of course, have the closed loop so that as new information is surfaced, be empathetic and reactive to actually new things as they arise.
And Fei-Fei, you've done groundbreaking work on bias and AI. And what are your thoughts on this question?
I think Andrew's answer is great. I think the most important thing is to recognize the human responsibility. I actually cringe when media tends to have a title, so-and-so's AI is biased, so AI is against certain group of people. I think that even that language puts the responsibility on the machine instead of the people. But there is no independent machine values. The design, development, and deployment of machines is on people, from the technologists to business leaders to the civil society. So recognizing the human responsibility is step one and the most critical step. And with that, recognizing that AI is a pipeline of a big system, from data curation to algorithm development, to inference, to decision making, to sometimes you bring back that human in the loop component. Every step of the way, biases can happen. And that bias, again, has a human factor, whoever is making decisions, whoever is carrying out the work. So not only we should be aware of the final biased outcome, we should be really aware of the upstream causes of where bias might come in, and really mitigate and put guardrails against that. And this is why, back to what I just said, bake the ethics into the design, get the stakeholders, before we even write a line of code, we get our ethicists, the legal scholars and patients and nurses into the room and talk about the potential issues. And then we start the design process. So yeah, it's a critical issue.
Yeah, and such an important point that as computer scientists, data scientists, statisticians tend to view the problem as one of the data, and how do we analyze the data to reduce bias, when in fact, bias is sometimes something that you have to address before you even collect the data. And
yes,
think about what
even
question you're asking.
Define the problem, yes.
What data are you collecting? Yeah, good. All right, let's move on to a question from Nikita. This is about the right balance between transparency and explainability as we deploy AI in the healthcare domain. So transparency of an algorithm can lead to trust, which is essential for people to understand how to process and maybe follow the advice. But it can also be difficult when proprietary technology is involved, where it's not always possible to be as transparent as a company might like if they want to maintain their proprietary technology. So what should companies supplying these products be required to disclose, and what should they be allowed to keep private? It's a difficult question.
Yeah, thank you, Nikita. It is a difficult question. Maybe I think of it, in terms of information and transparency. By the way, I know the popular answer is to say, of course, if you're fully transparent, healthcare demands it, people demands it. That's an easy answer. Let me try to give a more nuanced one. There's one framework I often use, which is what is the information that someone needs in order to do their job? Because if someone needs a piece of information to do their job, then I would feel a strong obligation to see if we can provide them that information. And I think that we talked about the proof of concept to production gap. I think that healthcare providers have a very legitimate need to double check if any of our AI systems are safe, or if there's going to be data-driven performance will degrade. I think we need to provide that transparency. I think patients have a very legitimate need to have the information needed to make decisions, in their own self-interest, and so do doctors and members of the healthcare system. And the fact is, I honestly don't think a healthcare system where we say the AI is 97% accuracy, even higher than doctors, just do what the AI says without asking any questions. I honestly don't think that will lead to better outcomes. And I don't think at this level of maturity of technology, I don't think we should design toward that. But I think one of the challenges of explainability is a lot of different things and purposes of explainability have been mushed together, which makes it a bag of very confusing things. So is the purpose to convince a doctor, tell a doctor what's going on? Is the purpose to audit the system against bias? Is the purpose to explain to an engineer where the errors are so they can carry out error analysis to improve the system? I find that one of the reasons explanation transparency is this tangled knot is because the conversations often mushes together the needs of different stakeholders and different technologies, but we separate out who needs to know what, then that often lets us design, the information they need. I want to share one example where I made a miss. It's really interesting what happened to us. So the palliative care systems I mentioned earlier, when we started using a learning algorithm to predict, patient has this chance of passing away, initially the doctors very reasonably said, what is this? And who are you to tell me that my patient is at high risk of mortality? Completely reasonable response. So what do we do? Anand Avanti, he wrote a system so that for every patient, he looked at the features that went in the prediction system to say, we think this patient has a 0.67 chance of passing away in the next 3 to 12 months because of this lab test, because of this lab, because of this diagnosis. And we thought, well, with this explanation, it'd be great, right? The doctors can look at it and see why we think the patient's a high risk mortality. What surprised me was the doctors took one quick look at it and doctor said, okay, got it, makes sense. And they never looked at the explanations again. Because what I totally missed was that the doctors didn't need us to explain to them why a certain patient's at high risk of mortality. The doctor could look at the folder, look at the chart of the patient and form a judgment really quickly themselves. They really did not need any explanation from us. But the reason they wanted to look at the explanation was because, frankly, they didn't trust the AI system, completely reasonable. And they needed a little bit of an explanation just for them to trust the AI system enough to be willing to consider using the AI system to prioritize what charts to look at in the future. But once they're looking at a chart, they really don't need our help to figure out what's going on really quickly. So I think even we, right? I missed the purpose of the explanation, but fortunately, and we built it, frankly, for the wrong purpose, which was to explain to the doctor what we're doing and to show them if what we're doing was actually reasonable or not. But there's some AI people that say, look, it's a black box. It does want to test that. Why do you need anything else? I just don't agree with that point of view. I think this is a multi-stakeholder thing with many people that need to understand and all participate in their roles. And I think explanations is critical for tying this complex set of activities from multiple people together so the healthcare system collectively can do what it needs to do and deliver great patient care.
Yeah. Fei-Fei, what do you, go ahead.
Yeah, so I think we need to take a look at the word transparency and also actually interpretability, because when this is a tendency of the AI community that we need to learn that when we think about something, we need to take an engineering approach. So we immediately think about transparency and explainability at the algorithm and engineering level. What is the neural network encode? What is the representation we're learning? Which part of the neural network is making the decision? That's just one type of transparency and interpretability. There's others. We had just a great talk by our colleague Nigam Shah at the HAI's event earlier, talking about different levels of interpretability and explainability. For example, there could be a causal one where we don't talk about the engineering under the hood explainability of the algorithm, but tell you if you take this drug, your pain would feel better. That's a causal explainability. It doesn't tell you the underlying molecular pathway of how this drug works, but it establishes one kind of explainability that might solicit trust. And then there is also a more direct, trustworthy kind of explainability and transparency. For example, you use a map app to go from point A to point B. Now it gives you choice. This route is the shortest, but you pay a toll. The other route is the more scenic route. And that is, even though sometimes I only just default need one kind of route, but knowing the system is giving me choices and allowing me to choose builds the trustworthiness through explainability of the output. So there are many levels of explainability and transparency. And in healthcare, this is extremely important. Just like Andrew said, just because we engineers think this is what it is, doesn't mean it's humanly useful. It doesn't mean it increases the trust or increases human dignity in the case of patients and healthcare workers. So I think so the way to balance this is really take a much more human-centered approach, in my opinion, where the multi-stakeholders, including from the customer, patients, all the way to policymakers, look at the different human aspect. And the objective shouldn't be making machines more transparent for the sake of making machines more transparent. The objective should be benefiting the humans and creating trustworthy technology that would serve that purpose.
Yeah, great points. And both of your answers really highlight the importance of trust and the fact that there are many ways to develop trust in an algorithm. And I always like to point out that there are many, many things that we do in medicine that we don't know how they work. We just have maybe a clinical trial that shows, Tylenol relieves pain. We don't know the mechanisms, we don't know the internal workings, but sometimes that's all that we need if that trial shows us. And so maybe we need those kinds of studies for some of our AI applications as well to show that, they work well in this particular group. With that, we have about 15 minutes left, so I'd like to open up the floor to answer some live questions we've received on Slido. And so I'll start with this question from Lan Lei. What are some of the most significant problems in healthcare that are yet to be solved by AI? So Fei-Fei, I'll start with you.
Hi, Lan. I want to give you a number, and the number is 250,000 people. And that number underscores annually how many people in America die in our healthcare system due to medical error. And that is exactly what Kurt was mentioning earlier. The healthcare, modern medicine has advanced a lot to the point we have a lot of good ideas, good drugs, good procedures. Of course, we'll continue to innovate, but not caring for human in the intended way, not by any evil intention, but because of fatigue, human error, lack of system resourcing, all this contribute a huge number of deaths and injuries in our healthcare system. So to me, that is what I want to highlight as one of the most significant problems in healthcare. If we can ensure that our medical procedures are carried out in a way that the doctors and clinicians intend to, if we can make sure we triage the diagnosis of patients in a timely way, if we can make sure our chronic disease patients and aging seniors at home are being contacted or cared in a timely way so that whatever condition they're developing are not deteriorating without notice, if we can make these things happen, we can save a lot of lives, we can make a lot of families happy, and we can save a lot of money in our healthcare system. So that is what ambient intelligence is about, is to shine light to this dark space of healthcare delivery, to be assistive to our clinicians and our patients and their families, to give that insight back so that we can catch the errors before they have an impact, or we can catch the moments the patients need help. So that's one significant problem.
And Andrew, how about you? Where do you think we should be investing our time and effort to solve healthcare problems today?
Yeah, I think the Fei-Fei gave one great one. I feel like, healthcare is a giant field, and I feel like there are, I don't know if it's hundreds of thousands of opportunities to do AI projects that make a huge difference. Just, I don't know, top of my mind, one thing I'm personally excited about, mental health. Frankly, we walk around even the streets of San Francisco, or actually about a month ago, I happened to be walking by a homeless encampment and went to speak with some of the individuals there. And I think, the behavior of some of the individuals there, right? I think, I'm not a doctor, but suggested that mental health tools may be helpful to deliver that in a more scalable way. But I think that there's a lot of work to be done in diagnostic capabilities. Here in the US, we're fortunate to have many good radiologists around the world. Most countries do not have sufficient radiologists, even if there are enough X-ray machines. So I'm seeing AI for radiology take off, especially in some developing economies, very early signs. But I think more broadly, diagnostic tools to help with many places, especially where there aren't enough doctors, which is most of the world. And then one part of healthcare that I think is often overlooked is the operational side of healthcare. So there's the clinical side, and then there's also the operational side. So it's like, maybe, I don't know, I think it's exciting stuff. Maybe some will think it's boring stuff. It's like just stuff like, how do you efficiently schedule patients for the MRI machine? Because you only have a few MRI machines. How do you schedule them so it's efficient, you get high utilization, and people can get their MRI scan as soon as possible, right? And just how do you help with routing, how do you schedule nurses so that nurses are well taken care of and patients are well taken care of? And how do you optimize the healthcare system with all of those little decisions on the operational side? when people think about AI in healthcare, a lot of people immediately think about the diagnostic or the treatment side. Super important, lots of options there. And I think there's been relatively little academic research, less proportionally on the operational side. And I think there's a lot of room to and I think we've all seen, right? One of our friends' partner had a bad car accident literally 2 weeks ago. Spoke with her, she's terrified of the healthcare costs and really worried about insurance. So I think that these things is like, yes, we're just making the healthcare system a bit more efficient, reducing costs, but the healthcare system is one of the places where cost reduction actually means a lot more people's lives. So that is important too.
Well, and it's a great point. And if we make a distinction between the great science of AI and the great innovations that are happening, and then what makes a good business out of an AI product, the products that are making those operational improvements are likely to have a return on investment for that customer and are more likely to make a market. So yeah, I think those operational areas present some really great opportunities. A question from Kyle, who wants to know about more about the barriers to accessing de-identified health data. So we hear a lot about data as a bottleneck, right, across industries. And I think it's fair to say it's probably a little bit greater bottleneck in healthcare because of the privacy issues that we need to face in de-identifying data. Fei-Fei, maybe go to you first. What are your thoughts on accessing health data for your work?
Yeah, I think this is one question, Kurt, you must chime in as well, because you're leading a lot of data efforts at Stanford. But yeah, happy to share. So first of all, respect of data, there is, as much as it's hard to access, there are a lot of data through the process of HIPAA and other regulatory measures. As researchers, we could access data, but I have a feeling that the question comes from two pain points. One is that just because Stanford researchers can access certain amount of data doesn't mean there's a good access to aggregated data that ensure better algorithms. And also, even if there were, it's Stanford researchers might be in a more privileged position. How does the entrepreneurs and other parts of the society access healthcare data? What I see is that, first of all, there needs to be a modernized effort in data curation and data repositories. There has been effort, right? Starting as far as I can remember, like DJ Patil and the Obama administration have had data.gov, where healthcare data was part of that effort. And also more and more, Kurt, you should really talk about how clinicians have come together to de-identify data and aggregate them in a way through licensing programs for people to access. I do think, wearing my hat as the co-director of HAI, this is a issue that we're talking actively with policymakers. And we think that, at least for the US, there needs to be a bigger effort in modernize our way of accessing healthcare data for new development, while protecting all the privacy and other issues of our patients. So I'm curious to hear, Kurt, some of your latest effort in this.
Yes, well, I agree with you. I think we have a number of strengths and weaknesses. The strengths, particularly at Stanford, we have an enlightened, I think, view of privacy and patient data, and recognizing that once the data has been used for patient care, the secondary uses really, it ought to be considered a public good, that it's really for the benefit of all of us. And we have an obligation to try to make that as available as we can, keeping the privacy and safety of the patients in our minds and protecting that, but to try to make it as available as possible. So at the AIMI Center, we've made now, I think, 9 or 10 data sets publicly available, with more in the pipeline that are AI ready, just to drive the field forward. I think that's very important. I also agree with you, Fei-Fei, that we need a refresh in the way that we think about these privacy regulations, because the penalties for a breach of privacy are are high, and they should be high. But I really think that that patients also want us. If you ask patients and look at the surveys, they want their data, if it's de-identified and their privacy is safe, they'd like to have that used for these kinds of innovations. So we have to think about what are the ways that we can encourage this kind of research while preserving patient privacy. Andrew, do you have thoughts?
Yeah, just two quick. So I think I'll just call out your AIMI.Stanford.edu. This is Kurt's organization, AIMI. .Stanford.edu has a list of data sets that really Kurt and his organization publish online. It's a great resource.
And that's been the work of Matt Lundgren primarily. He spearheaded that. Yes, thanks, Andrew.
And then I feel like there's actually one thing about AI. There's some data sets you can get online, right? Thanks to AIMI and organizations like that. And there's actually a view on AI that I feel like we should take as well, which is a lot of AI development has been very model centric, meaning researchers download a data set, hold the data set fixed, and they keep iterating on the model to try to get good performance. I feel like the field of AI should shift a little bit from being model centric to being data centric, where I now go to a lot of my teams and say, hey, everyone, the RetinaNet or UNet or whatever is good enough. So everyone, don't mess with it anymore. The only thing we're going to do is improve the quality of the data, and it'll be by improving the data that we can then get good performance more efficiently. So I think there's actually one big gap, not just in terms of online data sets, but in terms of ML ops tooling, thinking, and processes in AI, and how to take a data set, which is messy because almost all data sets are messy, and to not have an engineer hack around on the Jupyter notebook and hope they have the right insight to improve it, but to build tools and processes to improve it. I actually gave a long talk on some ML ops and shifting from model-centric to data-centric AI. And I think the whole world, healthcare, but really almost all fields in AI, maybe all fields in AI, are still in a very early stage and thinking through how to build a data-centric processes and tools to supporting machine learning development. So that's actually one big shift that I hope we collectively can make in AI and in healthcare.
Great. I guess we're coming close to the end. So I want to close with this question, maybe ask each of you, what do you see as, this is from Jack, what do you see as the biggest challenges or barriers to adoption of AI in healthcare? And just as kind of a follow-on, based on those challenges and barriers, where do you think we'll be in 10 years in terms of AI adoption? Andrew, maybe start with you.
Boy, I think there are multiple barriers. I think the software algorithms need to get better. We need to learn how to manage the full life cycle of machine learning project. ML ops needs to get better. We need to tackle the right problems. Sorry, there are multiple technical and non-technical change management problems that need to take place. In the tech world, progress tends to happen slowly and then very quickly. So I think we're still in the progress is happening slowly process of healthcare, where at Stanford and other institutions, we're starting to see things make it into the healthcare system, but it feels slow, and there are one or two isolated examples. What I hope will happen, and what I think will happen, is that these little sprouts of success stories will quickly be replicated and grow faster and faster. So I think that over the next decade, there will be a blossoming of AI in healthcare. But I think for the next few years, it'll continue to feel much slower than any of us wish. But once it happens quickly, which is not now, but a few years from now, maybe, I think it'll feel pretty unstoppable.
Great. And Fei-Fei, how about you? What do you see as barriers and where are we headed?
I think whenever there's a barrier, there's an opportunity. So what I see as the biggest opportunity / barrier is the human wind. Is that when I say human wind, is that we need AI and technology to prove that they make a fundamental human difference to the care or recovery or the well-being of either the patients or the healthcare workers' work. So I think that is, there has been a lot of excitement, and I continue to believe, like Andrew does, that this industry is so fundamentally important. The technology will help, but we need, for example, in radiology, right? We need a proven story or proven product that truly has not only helped diagnose patients, but also made radiologists work better and collectively move the needle. And with that, I think we will have a watershed moment of this this industry. I have no doubt it's going to happen, but I really want to. I'm eager to see that human win. And in terms of the next 10 years, never ask a scientist to predict, but if I have to bet, I do agree with Andrew. I think we're still in the midst of figuring out the path to the human win I talked about, or the path to commercialization, or however you call it. We are inching closer and closer to that watershed moment. And I do think within 10 years, it's very likely we will hit there. And I do want to acknowledge COVID. Where I am through the digital health angle, I think COVID has accelerated this process. The global pandemic has really re-emphasized or brought to the limelight the importance of telemedicine, the importance of making sure hospital delivery doesn't get over jammed and suddenly just overloaded, making sure people at home can be taken care of. Especially in my work, I watch a lot about aging population and see how they have suffered, not only just the virus itself, but also the overall well-being due to the healthcare system issues. So I think COVID has really accelerated our recognition of how important digital healthcare is.
Wonderful, thank you. That is all the time we have today. It was an incredibly inspiring conversation. Listening to the two of you, I can see why so many people are drawn to the mission of this field. I just would like to thank Fei-Fei and Andrew for being gracious with their time and expertise today, and to all of you in the audience for being here and sending such great questions. This event will be available as a recording within the next day or two, and it will be posted on the HI website and DeepLearning.AI's and the YouTube channel for DeepLearning.AI and for HI, and linked from the AIMI website as well. So thank you again, everyone, for your time. Thank you, Fei-Fei and Andrew, and for taking the time to hear about healthcare and AI today. Have a good day.
Thank you, Kurt. Thank you, Andrew. Bye.